Welcome, everyone. Thank you for joining the Technical Framework and Trusted Exchange track. We have a great panel of experts here today with us that will take you on a journey around the ecosystem infrastructure considerations and what it takes to facilitate exchange in the context of the transition from document-based exchange to exchanging health information using FHIR. Without further ado, since we have a lot of content to go through today, I will turn it into our session moderator, Alex Goss, who will get us on our way.
Well, thank you, Diana. Let's go ahead and take a look. We're going to start on slide 4 today. My name is Alex Goss. I work at Imprado, the consulting division of Dynavet Solutions. And thank you for attending today's session. I'm thrilled to moderate this panel as we have a dynamic team of presenters for you today. Their presentations speak to the benefits and considerations of transitioning from document-based exchange to exchange using FHIR. How to most effectively generate, transmit, and receive and use data is near and dear to me, as I've spent most of my 30-year career in healthcare working on projects and industry collaborations to improve information exchange capabilities and the business functions that depend on the data. I saw the dawn of HIPAA when I was working in Medicare Part B, and EDI was new. As Pennsylvania State Health IT Coordinator, I worked with various programs to advance meaningful use of electronic health records and health information exchange capabilities. Currently, as a consultant to the Da Vinci Project and member of the FAST Initiative, I'm seeing firsthand the value of fast healthcare interoperability resources, or FHIR, and the traction in leveraging the FHIR standard and implementation guides in achieving contemporary integration of system capabilities. The healthcare ecosystem is complex, as we all know. This slide provides a high-level view of the various stakeholders on the left that will use FHIR in various services. These services, based on standards and implementation specifications, are key to interoperability. The FHIR standard is advancing quickly because of highly focused initiatives addressing specific use cases to improve information exchange. Building on the investments to capture and digitize data, as well as applying lessons learned from prior industry standardization efforts, FHIR provides our healthcare industry a tremendous opportunity to modernize workflows because of the ability to receive discrete data and to have enhanced system automation. As we automate tasks, we free up our human resources to focus on helping patients and working on the more complex scenarios our citizens face in the delivery and reimbursement aspects of our healthcare system as they strive to improve their health status. Our technology journeys that include EDI, CCDA, IHE, and FHIR standards all have in common the need for trust among participants and for standards. I'm using the term standards in this case to refer broadly to the policy and technical frameworks we apply to accomplish a given task. The industry is key to building and maturing these standards to achieve our respective business models while caring for our citizens. While the patient sits at the center of care delivery, the ability to appropriately exchange and accurately interpret and use data is critical. As the ability to capture and digitize data becomes more ubiquitous, we have learned and applied the heartfelt experiences to improve technical exchange standards. We've also harnessed modern technologies to increase our data exchange capabilities, from strings of delimited data requiring extraction, transformation, and loading, to exchanging documents with blobs of text displayed in a viewer for human consumption, to specific exchange capabilities using discrete data enabling enhanced system integration and automated processes. Our presenters today will share their expertise and insights on why FHIR facilitates better information exchange than document approaches, how to achieve FHIR at scale, how networks advance trust and information exchange, and hear how the public healthcare reporting perspective can help advance electronic case reporting. Our first presenters today are from the New York eHealth Collaborative. Luke Doles, Senior Director of Service Management, and Dheeraj Kumar Pal, Senior Technical Lead and Architect, will kick us off. Our second presenter is Patrick Murtaugh, who is Chief Interoperability Architect and Fellow at Humana and member of the Da Vinci Project and its operating committee, whereas today he will be presenting with his FAST Chief Architect hat on. Our third presenter is Jason Vogt, Supervisor and Project Manager at Meditech and also the Chair of Commonwealth Standards, Technology, and Implementation Group, and he will talk about garnering trust through a network. Our final presenter is John Lunsk, Consulting CMIO for the Association of Public Health Laboratories and Adjunct Associate Professor, Johns Hopkins Bloomberg School of Public Health. He'll be addressing the ecosystem infrastructure and public health electronic case reporting. After our presentations, we will address questions you submit into the question panel. We've reserved approximately 20 to 30 minutes for questions and encourage you to submit questions as we go. Without any further ado, I'd like to turn it over to Luke to take us away.
Hi, I'm Luke Doles, working with New York eHealth Collaborative. Obviously, in New York, we have a number of HIEs, and we've been exchanging documents for approximately 5 years. And in some ways, it's been successful because it's viewing the documents in Clinical Viewer has been very helpful, but very limited. Because we have multiple HIEs, so you have multiple documents that can come for a single patient. So obviously some of the limitations of cross-community access is the size of documents for on-demand documents. There are multiple failure points along with many different of the clinical systems. We try to do weekly testing in production and have not been totally successful all the time. And then really the limitations of getting access to discrete data. We had one of our HIEs that wanted to get the last A1C for a patient cohort, and they had to retrieve the entire document and then, basically parse that across. So about a year ago, we started creating a FHIR framework implementation. Basically, with FHIR endpoints, we have a centralized service that can go and retrieve FHIR resources. We limited it to, just the 3 basic FHIR resources of patient, condition, and observation. And then going forward, we're looking to expand the resources to actually help with our public health integration for basically COVID. I'll turn it over to Diraj.
Thank you, Luke. As Luke mentioned, we have been in the this IHE business like almost 7 years, and we have been kind of trying to get like a complete set every time we test with the production. And being a CCDA, sometimes it's like a lot of data and other issues happening, and then you're exchanging multiple networks. So there's like a very few times we had 100% success. That moved us to going to the FHIR, and then when we saw the FHIR, oh my God, that's something what we want to go for, because that gives us an opportunity to share the discrete data. And we started, as Luke mentioned, last year when we started building up the kind of a FHIR network in parallel to our current IHE network, which is connecting all the RIOs, all the QEs. And so we are trying to build a centralized service. And because New York eHealth Collaborative also maintains the statewide master patient index, and I mean, that's the SMPI, we call it. And that gives us make us in a position where we can kind of fan out to multiple QEs or RIOs to pull the data. And so our Fire Central services will be connecting to the SMPI to get the patient's location. And then we have like a two kind of a model, like where we get a data from one single source or we get a data from multiple source. And we will go in more detail as we move ahead. And the next aspect of that design was the security. Currently, because we are dealing with all trusted entities, like all the RIOs, regional health organizations, so we are basically based on kind of a IP whitelisting, SSL, mutual TLS in place. But the design is in such a way that it has a capability of going to the OAuth implementation if we have to open it to the kind of a world or internet. So that's a kind of a high level of the central services, what we are designing at the state. So what we're seeing on the screen here is basically how the DOH or any public entity wants, if they have to pull the data from this network, which is connecting across the Shiny, we call it Shiny, that's a statewide network, basically managed by the DOH. So any public entity will be sending a request to us, and that's what you see in the between and below is the Fire Central services, and then another small blue stuff is that's our SMPI, where we have which is basically a patient locator. Any request coming in, it will be kind of two kind of requests. One request is just to find out a patient. And that will be a PICS-M, which is a FHIR-based IHE profiles for patient search. And then other type of request will be like asking for the actual clinical data. That will be a FHIR resource. So whenever request comes in, we check it, what kind of request it is. Is it a PICS-M or it is the resource? And then, as I mentioned in the previous slide, that we will have like a single source data or the multiple source data. So that will be like decided in the second diamond here. And if it is for the single source, only thing we do is like just reach out to that single source to get the data, and that you see in the orange target QE. If it is from the state, if they want the data from across the state, if the patient exists at the multiple places, multiple RIOs, now what we do is we connect our request response processor to the SMPI connector, and now SMPI does the PICS-M, figure out where the patient exists, and then reach out to all the sources and get the data from them. So that's this everything happens in one particular call. When you request, you tell me I want data from statewide, and we will go ahead and figure out where all it exists and pull the data and provide you everything. Or another flavor of the same thing we have done is we split this these two processes in two parts. Like that, you go ahead and query the patient, and once you query the patient, you will know, or we will respond you where all that patient exists. And in that case, you can make a decision which source you want to get the data from. And in this the screen on the PPT you have in front of you, the first left-hand side is the step one, where you're querying the RSMPI using the PICS-M. Right-hand side, we have, okay, now you know that patient exists at place X, Y, Z. Now you can go ahead and choose which place you want the data from. And that will be the second right-hand side, the diagram. That will be like, okay, I need the encounters for the patient X from the source Y. And that will go ahead and directly go to the source Y and get the data and present to you. So far, I mean, design-wise, everything looked good. But when we actually started talking about now, okay, I have a data from multiple sources, how I'm going to present this data to whoever is requesting it. And the challenges we had, like, because we are not the one who is going to look at the actual clinical data. Now we are sitting in between. We just pass through kind of a service where we know that where the data is, we go there, we pull the data and provide the data to the requester. Now, if I'm getting a multiple sources response, the challenge is how should I bundle it? Then we started looking at the FHIR spec, and we found that there is FHIR does not support nested bundle. And because of the policy and because of the kind of a nature of our business, we don't want to touch the actual data. So we decided, okay, we'll create a nested bundle and puts all the responses as we received from the source and share with the requester. The question was like, because it is not going to be as per the specification, because this is something FHIR does not support. So we had a discussion with some of the FHIR resources directly, Graham Grieve and some other people. And we have proposed this as a kind of a change in the specification, or if they have some alternative for us. But till time, this is a solution which is like accepted, and we will be presenting this. We will be implementing that. The benefit of this kind of solution will be like because now we are talking about QHIN and the kind of a federal level network or NHIN kind of integration. This will help if we want to trace down any kind of transaction, which actual source has presented the data, because we are bundling or creating a compartment for each sources. That way, now we can trace down till the end and find out where exactly data came from. And the other benefit is like these kind of things will be presented as it is to the source without any changes. So if there is a question about the data itself, then we being in between, we are not kind of actually responsible for the data itself. So we can work both the parties and get the things resolved, but this doesn't put us on the liability because we are not touching the data. And this will be like, as I mentioned, it could be helpful at the national level healthcare networks when we start getting into that. So that's pretty much from the New York Health Collaborative side design perspective, what we are building. So I'll forward the next slide to the next presenter. Thank you.
Great. Well, thank you, Dheeraj. That was a great introduction, and Luke also to the New York model. And also thank you, Alex, for that warm introduction. To add a little bit of color commentary to what Alex was saying is that I do go back as well to the early days of HIPAA. So I grew up in the world of HIPAA integration, also the HL7B2, CCDAs, and over the last several years have been focusing on FHIR. So a little bit of perspective there. And what I want to do today is, quickly go through what we're doing from a FHIR at Scale task force, the FAST initiative. I have the honor of serving as one of the co-architects on this project. So before we jump into it, again, as a public-private hybrid, the FAST initiative does run under the antitrust model. So folks that belong to FAST come from the spectrum of healthcare. We have payers, we have EHR vendors, we have folks from CMS and ONC, of course, EHR vendors, software vendors as well. So folks that would, in certain circumstances, be considered competitors. From a FAST initiative, we certainly run under the antitrust notice. So things that we discussed in FAST, we will discuss publicly, but we don't do anything that's confidential or proprietary. So I promise I'm not going to read this entire notice to you, but please recognize that we do operate under these rules. All right, so what is FAST? FAST is an initiative. It's a public-private model that was convened by Dr. Rucker, the ONC, of course, about 2.5 years ago. And FAST has a unique perspective on what we are trying to do from a FHIR ecosystem perspective. So where we're going to walk through some of the models with DaVinci and Argonaut and a few other HL7 accelerators in which they are focused on functional use cases. The FAST initiative, again, as a public-private hybrid model, is focused on infrastructure to make sure that we can run FHIR at scale. So as we walk through the next couple of slides, we're going to walk through some of the diagrams that help us illustrate where some of the HL7 accelerators fit in as far as the functionality, and also where FAST comes in as it relates to making sure that as a nation, we have the infrastructure and the models in place to be able to support FHIR, not just from a point-to-point communication perspective between two actors, but across the gamut of healthcare. All right, so I'm going to start with a really, really simple picture. It's almost looks like it could have been done by somebody with Crayola crayons, but it basically represents how the current model works, right, from a very, very high level. So if you temporarily work with me and go into the world of what an animation or suspend your logic for a second, is that imagine those cars, trucks, vans, and motor scooters as functional use cases. So they could be prior authorization, they could be cross-transparency, whatever use case that you like from a fire perspective. And then, of course, we have on the left side, looks like a small clinic. And on the right side, it could be a hospital, it could be a payer, could be a larger organization. And those vehicles, as fire transactions or fire use cases, need to get from point A to point B and back. Now, in this model, each one of these has unfortunately built their own roadway, right? So the person on the little motor scooter has their own personal road from the clinic on the left to the health plan on the right. And same as with the red, van and the school bus, it looks like, and the car on the right side as well. And although that works at small scale, meaning that each of those transactions, functionally work, you can get from point A to point B, it doesn't scale very well because each use case or each fire resource or each integration should not have to lay its own roadwork. Let's look at a different model in which we have a well-planned infrastructure which creates efficiencies. So the functional use cases are the same. We've got the same vehicles, the same functional use cases that we talked on the previous slide, but we've got a much more organized model as it relates to sharing information. For example, we've got a nice roadway with dotted lines down the middle. We've got a street sign that says this way. We've got a stoplight. So we've got a lot of organizations. The functionality is the same, except each of those use cases or each of those implementations did not need to build their own roadway. They're sharing a shared model or a shared implementation approach to sharing information. Okay, so now that we've talked very high level about what FAST is attempting to do from an infrastructure perspective, let's go a little bit deeper and talk about the FAST organization and community engagement model. Now, the base of everything that we do from a FAST perspective is primarily focused or originates from what we do from a Tiger team. So if you look in the lower left corner, you see that we have Tiger teams which focus on certain areas of infrastructure as it relates to fire scaling. The first one, the ecosystem use cases, was originally created so that we could determine which use cases that we needed to focus on as a consortium as it relates to infrastructure. And that may sound really, really easy, but the fact that we're not dealing with, a web screen or some piece of functional data, we're talking about scale, puts some unique perspective on how to develop ecosystem use cases. We also have an identity Tiger team that focuses on how we do identity management and patient matching across different actors in the ecosystem. We've got security, of course, which focuses on how do we ensure that security is honored and respected across the ecosystem as well. Directory versioning and scale. How do we make sure that we understand how to talk to other endpoints? And we're going to go through that a little bit more detail in just a second. I know that may seem a little bit esoteric at this point. Also, how do we exchange information? Given the fact that there are intermediaries in healthcare, the ability to send transactions across intermediaries, potentially several, before the transaction gets to its ultimate destination and back is something quite important as well. The ability to do testing and certification to make sure that as folks are onboarding to the FAST initiative or to the FAST model, we as participants can be assured that they've met a certain level of criteria to be able to play in that space, and also the ability to pilot these ecosystem use cases in relation to the other functional use cases that we are focusing on as well. So the Tiger teams of the core are the core of everything that we do. Around that circle, we also have a coordinating committee, which is make sure that as the Tiger teams are generating artifacts and doing great work, that we're coordinating across the spectrum. We also have an executive steering committee, which is basically consists of both public and private executives across the industry, so that they meet quarterly and typically provide guidance from a very high level on the work that's happening from a Tiger team perspective, a coordinating committee perspective, and things that we're planning out for the future. Outside of that primary or that focus in the circle there, we also have other resources and other teams that help us because we don't want to develop anything in a vacuum. So as the artifacts have been developed over the last couple of years, we've had a couple of different approaches to engage folks. For example, last fall, in the November-December timeframe, we had a series of HL7 webinars in which we basically walked through the version 1s of the artifacts, got feedback, right? You see the feedback look on the top there. They went through a period of revisions, and over the last 8 weeks, we went through another period of subject matter expert review again, in which folks provided additional feedback on version 2 of the documents. And now we're going through and incorporating that feedback and going for version 3 of the documents as well. We also have, Confluence sites and websites, other types of LinkedIn group engagements. I think we've got a slide at the end that provides a little bit more information on that. But a shameless plug that we are always looking for folks to help, drive this effort forward. So if you're interested, one of the last slides will be a way to engage with us. Okay, so let's talk about where FAST fits into the overall, healthcare model that's evolving with FHIR. On the left side, we see the HL7 FHIR accelerators, and some of you on the call are probably very familiar with these, maybe even involved in these, or at least looking at some of the artifacts. But we've got the Da Vinci initiative, which focuses on mostly value-based care use cases, the Argonaut project, which focuses on core data services, Care and Alliance, which of course is consumer mediation, Gravity, which is social determinant health, and I could go on and on. The key focus of each of these groups is functionality, right? Some level of functionality within healthcare, whether it be, payer to provider integration for prior auth, how do we do consent, with Argonaut, how do we ensure consumer mediation, that type of thing. So these groups focus on how do we move functionality forward, right? On the one step to the right, we see, the contractual enforcements, care, quality, and commonwealth, but right below that, we now see what FAST is all about, scalability. So FAST is concerned with making sure that we have the right infrastructure in place so that all of the other players that are producing functional use cases can run at scale. So things that I mentioned before, directory, versioning, exchange processes, those types of things that are not necessarily concerned with the underlying payload or the underlying content, but ensuring that that payload can run at very, very, very high scale. And like we did on the previous slide, think about the folks on the left with Da Vinci, Argonaut, and the others providing the vehicles, car, trucks, vans, motor scooters, whatever your preferred vehicle is, where the FAST initiative is concerned with making sure that we have the roadways and the bridges and the stoplights and that type of things so that those vehicles can get where they need to get with the appropriate ability to navigate and get there in a reasonable amount of time. Okay, so now that we've got a high-level overview of what FAST is concerned with, let's take it down one level and talk about the solutions process, and then we're going to actually walk through a couple of these solutions at a fairly high level. But again, we've talked about the Tiger teams. Again, that's the core of what we do from a FAST perspective. Those Tiger teams operate on barriers or core capabilities that were derived from the use cases. Again, going back to what I discussed a minute ago, the ecosystem use case team developed a series of use cases. From those use cases, we derived core capabilities such as directory, identity, security, those types of things, and also any perceived or real technical barriers that we already knew that was organically happening in healthcare. So they focused on that. They came up with proposed solutions. And those proposed solutions went through a series of reviews end of last year, like I talked about before. We went through version 3. We just finished that a couple of weeks ago. And now we're in a period of doing additional reconciliation, additional feedback incorporation into those documents. But what happens after that, right? So after we get through with version 3, which will happen in the next couple of months, several things can come out of that. The first is potentially a recommendation for an update to standards or an update to a process or potentially even a regulatory change, right? That won't be the end of the process. It will still go through evaluation, feedback. We've got some additional piloting to go through. Operationalizing those solutions as well. That's no easy task. So there's a lot of work that needs to happen from that perspective. Also recognizing who the long-term owner of these frameworks or these solutions will be, right? So the FAST initiative is chartered with making sure that we stand up these frameworks, start moving them forward, but the ultimate owners of these solutions could, run the gamut. It could be a standards body. It could be a government agency. It could be a private organization that focuses on enforcing standards or recommending standards and those types of things. So there's a lot of opportunities and a lot of work that still needs to happen to determine what the actual or who the long-term owner of these solutions may be. Okay, so let's quickly walk through. Again, we could spend days and hours and weeks on, the fast proposed solutions, but I know that we're on a tight time schedule today. So let's just quickly walk through what these frameworks look like from a very, very high level. Endpoint discovery. In today's world, to exchange FHIR transactions, you typically need, not typically, you do need to know or have knowledge of what your partner's endpoint is before initiating the transaction. There needs to be some communication, where his FHIR server is, what version it's running. You need to be able to read the conformance or capability statement and that type of thing. And that works at a relatively low scale. But when we get, all payers and providers and EHRs and public health and everybody involved in this model, the ability to discover endpoints dynamically is going to be critical because things will change. We'll add additional partners. So the ability to read or to be able to interact with an API that will give you an endpoint listing for the actor that you're attempting to share information with is going to be very, very, very critical, right? A lot of us call it the DNS for FHIR endpoints or clinical endpoints. It's basically a model in which you can interact with a service and determine what the FHIR server or what the endpoint is that you need that you can talk to. It's not, you don't call your friend down the street or whatever, send an email. You're able to discover that information in real time. Also, determining what version of FHIR an endpoint is using or a remote FHIR server is using. Again, the same directory in which you're able to determine what the address is will also give you an indication of what version of FHIR they're supporting. The ability to scale across intermediaries and use RESTful exchange across HIEs and across clearinghouses and those types of things is something that the team is focused on as well. Identity management, right? The ability to determine from any actor to another actor who the patient is or the provider is quite important. The old days of requiring that all actors understand every other actor's unique identifier doesn't scale. So the ability to have a trusted model in which we can reconcile identity on the fly is going to be critical as well. Intermediary to intermediary solution. So the ability for those FHIR services with their RESTful headers to be able to have enough information as part of the metadata within the RESTful header to determine to document who the transaction has come from, and the originator and the receiver is important to ensure that transactions can run across an infinite number. Infinite's a really large number, but more than one intermediary. Again, we talked about testing and certification, the ability for folks to be ensured that as others onboard to the process, they went through a certain level of certification to ensure their ability to play at scale. And also, of course, security solutions. And again, we could spend days talking about that Adele with UDAP, Trusted Dynamic Client Registration, and others. But the fact that as security, goes between different parts of the ecosystem, we've got to be sure that we're all running on the same standards, that we're all respecting the same protocols, and that type of thing. I think Jason, in one of his slides, is going to talk through some of this as far as some of the work that he is doing and his initiatives. But the fact that it's got to be a standard that we can all follow and we can all adopt across the ecosystem in general. Okay, so really quickly, I know I'm going pretty tight on time here, is let's talk about a transaction. And again, I'm going to go pretty quickly through this, but let's explain or let's walk through what a transaction looks like through the FHIR ecosystem. Now, in this particular model, we've got a PCP on the left and we've got a payer on the right. Substitute any two actors that you want, right? Any use case that you want across the scale. It doesn't have to be a payer or a PCP. It could be a specialist, could be public health, could be pop health, whatever the case may be. But the steps that a transaction needs to go through to get from 1 to 6 or point A to point B are very, very similar. And again, they relate back to the core capabilities that I was talking about just a second ago. The first is you need to know what the endpoint is that you're trying to integrate with the other actor. Right, so the ability to use that API-enabled national directory is key. You also need to make sure that your transaction has enough header information so that regardless of the number of intermediaries that it goes through, it can be routed to the appropriate receiver, right? The ability to know the version, and we talked about that a few minutes ago, of the remote endpoint so that you're working with the appropriate version of FHIR. Identity, again, understanding that as a patient or a member is going through the different actors, the fact that we've got to agree that patient A in the EHR is patient A in the payer or the pop health tool or whatever the case may be. Again, security is a key thing, both from an authentication and an authorization. Is this person have the appropriate security to access this data? Can we be sure that we're dealing with a trusted source? And then again, conformance and certification, like we talked about a second ago, and also the piloting group, which has been working for a year or so, but is really starting to hit the ground running as far as partnering with some of those other initiatives that I talked about to be able to test some of these core capabilities or fast functionality at scale. And then I think as we get close to wrapping up the FAST initiative, again, just to quickly recap, is that we've got a series or a group of capabilities that FAST is in the process of documenting, right? They are standalone capabilities, but they need to be able to work together to come up to basically enable a coordinated ecosystem for sharing information. And again, I sound like a broken record, so I don't want to go through these again individually, but you see kind of going from the bottom all the way up to the top is that we've got a national directory in which the endpoints can determine who the other endpoint is and make sure that they have the right URL to talk to, the ability to do identity resolution between the actors, the ability to support intermediaries, right? Because given healthcare, we recognize that it's going to be a hybrid model. Some of it may be dynamic point-to-point communication, but there's also very valid use cases for using intermediaries. So we need to be able to support that model as well. Exchanging the right metadata in the headers is critical for that. And also the security model, authentication and authorization, which kind of wraps the entire envelope so that we can, basically ensure that transactions from beginning to end have the appropriate security and that the information is being secured both in flight and for proper usage. And again, at the bottom, conformance and certification, and also the piloting model, which is starting to roll out. And as I noted before, here are some contact information that if you're interested in FAST, we've got LinkedIn groups. We've got some names on here. Steph and Kanya from ONC, and also Diana from ONC are listed on here as well. But feel free to reach out to us and get involved. And with that being said, I am going to kick it over to Jason to talk about trust.
All right, thanks, Patrick. Thanks for teeing up some of my topics for me right away. So this should be an easy transition. So I think a lot of you have heard in the last day, yesterday, and even today, right? Like there's lots of different standards out there. We want to go to FHIR. We want to have it scalable, but we also have to, be secure and have privacy and all that stuff. And there's a lot of people that say, okay, I want to do this. I want to have FHIR. I want to be able to connect to payers and providers and all that stuff. And there's UDAP and there's OAuth 2, and there's a lot of standards that can be adopted. The biggest question that still needs to be answered in my eyes is how do we garner trust through all that process, right? Like I need to trust the client that's making the request on my FHIR server. I need to then trust them that when I give them the data, they're going to be good actors for them. There's lots of different, alliances that are helping push some of these forward, but at times we need somebody to kind of bring them all together. And that's where I feel like our networks, our trust frameworks, Commonwealth, Care Equality are really going to help drive the industry, because a lot of the needs to build that trust are inherent in our ecosystems, because that's basically the whole reason that we created the networks, is to help build that trust relationship through various different means. So, I work at Meditech, and the biggest or the easiest way for us to help get our FHIR endpoints out there and build this trust and live in thrive in this ecosystem is through our partnership with Commonwealth. And I'm kind of here today as the Commonwealth Standards Technology Implementation Group chair to kind of push this idea forward a little bit. So for those that are not familiar with Commonwealth at all, here's just a quick slide of kind of what we do. We have our record locator service, which helps us know where in the country this patient has been. We have our own patient ID and linking through our LOLA mechanisms. So this is with the record locator service, we're able to say, okay, this is the patient, here's where they have been, and we can link them all together. So we kind of solve that ID issue, right? Like who is this person and what's their ID at this other organization? We can help solve some of those issues. And then on the part that makes Commonwealth unique is we have the data broker kind of sitting in the middle of that, so that we can go to them to say, okay, where has this patient been? I need their documents. Please go get them. And the only part that makes all of that work is the trust framework. And that's kind of what I want to talk about today, right? Like, how do we build trust across this vast FHIR network? We need to make it scalable, as Patrick alluded to in his discussions, but we also need to make it secure. We need to build that trust in the network. Like, we can't have dynamic registration without trusted dynamic client registration, right? Like, we know in the Cameron one before this, in the API one, we talked about trusted versus untrusted, and we really need to push that trusted version, because if we don't have the trusted version, we're slow and we're not fitting the needs of our patients. So to me, the way the networks do this is establishing the trust is through lots of different policies and processes that we have in our organizations. Like the Commonwealth Network, Commonwealth Health Alliance Network, it's not a standards body. We don't try to create standards. We want to implement standards. So we work with the FAST initiative to say, okay, here's what we've learned from trying to scale, right? Like, we have 80 different members that are part of Commonwealth. We need to scale. We need to be able to do this. We scaled first with document query and retrieval, and now we were looking at scaling through FHIR. So the way we do that is through a lot of our governance policies and procedures, which help build that trust. If we can all agree on the way to do something, we can all trust now that that person is going to do that. We then take the work that we want to do or the use cases, and we send that out to the different committees and work groups to dig into that. We have a privacy and security one. How do we know the patient is who they say they are? How do we do that patient identification? How do we secure the endpoints to make sure that whomever is asking me to do the client registration is indeed a trusted client? Like, how are we going to do that? We have various layered security protocols between us and our broker, so that when we're connecting to the broker knows exactly who's asking, and they can garner that trust to the responder as well and make that multiple layered security protocols successful. The best way to do that is actually through our certification methods, right? Like, the reason we're very successful is because we all have agreed that we're going to do it the same way, but B, we also certify that we are doing it that way. And I think that is the biggest piece of the trust that we really need to kind of strive for in our industry is, how do we build that trust? How do we continue to say they are doing what they're supposed to do? And that's where the certification, the member testing, and the piloting has really made us successful. We have a new use case. Okay, that's great. Okay, how do we want to do that? Okay, here is our initial design. We then take that initial design, we actually send it out to pilots, real life production environments that say, okay, we want to do notifications now. How does this work? Okay, we've learned a lot. Let's bring it back. Let's alter it. Let's get that approved. And now it's ready for general availability. And the governance in the Alliance really helps to drive that forward, so that we know, every member that is out there is doing what they say they're going to do that. And if they're not, we have governance in place to correct it. And then I guess the next part that the network is going to help with is, okay, we can handle security, we can make sure everybody's doing the implementation standards, but the next set is, now we can also advance the data quality of the data as well. We have committees right now in Commonwealth that are looking at the CCDA. We have a joint document group with Care Quality that are looking at our documents and saying, what do we want to do better? How do we want to do that better? And then taking that and bringing it to HL7 and other groups and saying, hey, here's the standards that we want to strive for, and this is going to produce better data quality. You know, we pushed clinical notes already 2 years ago when we came up with our first draft. We're pushing lab results in our current draft that we're looking at for the joint document piece. For quality and Commonwealth specifically, like we're looking at all the different measures that we want to try to capture to say, okay, we're missing data here, where, the long code set's being used here. And then we can increase the quality of our documents. And then once FHIR is enabled and we're scaling it, we can also look at increasing the effective data in there, like making sure that the quality is there, both FHIR related and CCDA related, and keep driving the industry forward to say, let's all agree to this standard, and then let's enforce it through the network, saying that, yes, this organization is outputting their allergies correctly. This organization has all of their conditions sent out discreetly. That's building on that data. So a lot of those policies and things are in place in these networks. And I think that can potentially help drive our industry forward to say, okay, I need to be trusted. How do I get that trust easily? An easy onboard to trust is through the networks and the trust frameworks. Is you can easily get on there, you can get there, you can pay your dues, and you can say, okay, I'm here, here's my Commonwealth certificate or my care quality certificate. I'm a trusted entity, I have done my certification, and I can easily onboard to say, now I have access to the full breadth of information here in these networks. And to look at the size of the networks, like everyone likes to see the little fancy graphics. So here's the kind of the participating Commonwealth organizations across the country and Puerto Rico. Approximately 80 members, 17,000 provider sites, 93 million unique individuals, and then we have sent and retrieved over 513 million documents as of today. We average on a given day between 1 to 2 million documents per day of data exchange across the network. And if we can continue to build that trust through the document exchange, then build it through FHIR, we can then take that and we can continue to scale it. Networks can talk to networks. Commonwealth Care Quality do that today. I can go to the network and I can say, hey, give me I need a document for the patient A, and they can go to Care Quality and say, hey, do you have patient A? Oh, I do. Here's the 3 locations. I can get those documents back. And we can continue to build this trust both within an individual network and then start establishing those trusts from organization or from network to network or network to trusted framework, and continue to drive all these forward. And I think that's where the trust really gets built up, is establishing agreed upon principles. And I think that might be easiest in these different networks and trust frameworks. So I'm going to try to keep it a little short here and leave it at that. And I'm going to turn it over to John and let him talk about electronic case recording.
Thank you. Greetings, everyone. I am going to talk about electronic case reporting, and that's the automated identification of reportable events in EHRs and their transmission to state and local public health agencies. Certainly, it is a timely discussion in that regard with COVID-19, but it also really presses on this issue of interoperability at scale and the placement of FHIR in that regard. COVID-19 has obviously stressed the health system. We had limited implementations of electronic case reporting at the start of COVID-19, and we had a number of challenges that we were working through relative to both the trust aspects that have been talked about here already and the technical aspects of implementation relative to moving forward. To be clear, implementing reporting at scale involves comporting with only providing the specific data that are required by laws, and that's a complicated area. Anyone who has dealt with compliance officers or lawyers in the health system understands that they will only release the specific data that are appropriate to the purpose. But at the same time, the management of selective authorization to external organizational query is a huge burden. So the concept of querying in and only getting the data needed for that specific purpose represents a specific management, a very complex management implementation and operationalization that has not largely been endeavored. So some of that has led to implementations of scale as being organization-based in terms of their authentication and authorization and not individual-based. And that's one of the themes I'm going to talk about, as well as the varying levels of technology in the different environments that are out there. So at the start of COVID-19, we, as I said, had a limited number of implementations. We had a shared infrastructure that allowed for electronic health record vendors to report in one way to one place and have the shared services platform that is APHL AIMS and the reportable condition knowledge management system project from the CDC and the Council of State and Territorial Epidemiologists handle the delivery to the appropriate public health agencies. There are laws and rules written into this knowledge engine that are important to appropriately deliver just the data necessary for case reporting to the appropriate public health agencies, and to get the data, the right data out of electronic health records. We have distributed a series of trigger codes that will trigger the transmission of just the right, the likely reportable conditions out with that. All of that infrastructure and all those acronyms I just alluded to are really dependent on trust and a chain of trust between the providers and the APHL AIMS platform that is acting on their behalf. At the start of COVID, we had a partnership with eHealth Exchange, but we're pleased during the course of the COVID emergency to team also with Carequality, which implemented rapidly a second use case for their network, which allowed for electronic case reporting for all Carequality implementers, as well as those that are connected to Carequality implementers. And that would include Commonwealth participants as well. We already had eHealth Exchange partnership, which meant that any eHealth Exchange participant or anyone connected to an eHealth Exchange participant that was under the flow down of the DRSA could also do electronic case reporting without any additional agreement. So from a policy standpoint, in these short months, we have progressed tremendously to a trust network for electronic case reporting that extends from eHealth Exchange and their participants and those connected to them, to Carequality and their implementers and those connected to them, all the way to Commonwealth and the many participants that were alluded to in the last presentation. The basis for that trust network, though, also is the appropriate and selective delivery of just the right data necessary to do electronic case reporting, and the authentication and authorization services that are based on organizations making those exchanges. So each of the implementers that I just talked about have had a trust relationship with the APHL AIMS platform, and then APHL AIMS makes a public health disclosure to the public health agencies to complete the necessary activity of case reporting to meet state laws in this regard. There are technology challenges that align with the specifics of the policy challenges that I just alluded to. Clearly, not all of the public health agencies and all of the EHR vendors are exactly on the same technology implementation. They and the brokering of that, the variance between them, is a critical function that the APHL AIMS platform is also playing. Right now, no public health agencies use FHIR for support of electronic case reporting, but we have developed a FHIR technology, a technical solution, the ECR Now FHIR app, that takes advantage of what FHIR offers with the electronic health records to enable us to convey the technology of electronic case reporting to EHR vendors that have not already implemented it. So at the start of COVID-19, we had a limited number of EHRs that actually had a technical solution for electronic case reporting, even though it was in meaningful use stage 3, and it was also in CMS is promoting interoperability. It was in as a menu choice, and the pressures to move forward with technical solutions have been more limited as those programs have progressed. One of the implementers has been Epic, and we have worked with Epic during the course of the COVID-19 pandemic to do rapid onboarding and implementation in a technical solution that's based on CDA, based on Epic managing the trigger codes, based on them creating the electronic initial case report, and then transmitting on to the AIMS platform for the rest of the infrastructure alluded to here. At the same time, we built the electronic case reporting, or the ECR Now Fire app, as a way of conveying the technology for electronic case reporting to EHR vendors that did not have it. And we have now moved forward in that regard with several EHR vendors, Cerner among them, that have committed to implementing the ECR Now app so that all of their customers can be brought up to speed to do electronic case reporting using these technologies. The ECR Now app handles a lot of that functionality that of electronic case reporting, handles the trigger codes, handles the development of the message to send out, and it also sends out a CDA message into this infrastructure. So it's really a hybrid that is implemented to take advantage of the Fire API and all the great Argonaut work and other work on DSTU2 implementation of the API in electronic health records. It also can work with the R4 Fire implementations as well. And that's what Cerner and Athena Health have committed to implementing as they move forward, implementing the ECR Now app in their technologies. But this ability to convey that infrastructure in a rapid setting to EHR vendors that did not have it to move forward with these capabilities really is a testament to the capabilities of the technical capabilities of Fire and the ability to take advantage of that standard-based API to enable those capabilities broadly. So just during COVID, we have now come up and done implementations through the rapid onboarding process, through partnering with EHR vendors and health systems nationwide, with what is now actually over 3,800 sites that are now reporting for COVID-19. So since I made these slides, we've jumped another 800 plus sites. We've implemented and developed, transmitted, that is, over 1.2 million COVID-19 reports, and have delivered them to 52 out of 58 state and large locals who have the ability to either integrate them into their surveillance system or view them as rendered HTML to work on this integration issue, this common technical implementation, and to bridge what clinical care can do and what public health can do as we all move toward common and shared standards. So electronic case reporting, this is a great story to talk about rapid implementation in the course of a pandemic, and the accomplishments of both the trust framework and network that have been built out there, the eHealth Exchange, Care Equality, Commonwealth, to facilitate that activity, but also a real testament to the technical possibilities of the Fire API and ways in which it can help foster moving forward technical solutions that can also meet pressing and emergent needs. And thank you for your attention. I think we're going to turn now to Q&A.
Thank you. A terrific set of presentations. We've had some questions coming in as we've been going along. First, I want to sort of say thank you to all the presenters for helping to put together a story that talks about the various pieces of the fire ecosystem that are all working together to advance us to more discrete data sharing and increased opportunities for automation and more wise use of our resources, leveraging these new and emerging standards. We do have some technical learning communities that we had a couple questions come in. And so we answered a couple of those questions along the way. Wanted to let folks know that there was a LinkedIn community for FAST that they can participate in and track. There's also a ton of resources for the Fire at Scale Task Force, or FAST. The Confluence collaboration space is also, that link is also pasted in the answered question portion. There are a few other questions that we haven't answered yet, so I'm going to go ahead and kick us off while folks may also be submitting some additional questions. I'm going to start way back at the beginning of the first question that came in shortly after our friends at the New York Health Collaborative spoke. And the question for them was for the New York State proposed statewide architecture. How is the MPI maintained to ensure deduplication of patients across the state? It was noted that this is often challenging even with a single healthcare organization. Is there a team staffed to working with organizations to link and merge patient records and do unmerge and error corrections for scenarios where data might have been sent to orgs due to an inaccurate link? With the approach you've taken to aggregation rather than delivering CCDA documents, it seems like accuracy in the master patient index is even more critical than it might have been before. So I invite our friends at Luke and Diraj to maybe take a stab at that before others may want to weigh in on from their own experience.
Diraj, maybe I'll start. We have a very conservative matching algorithm, and we also use referential data to do some matching. We don't do a lot of maintenance at the statewide MPI, but obviously our RIOs have their own MPIs where they do data stewardship, et cetera. I don't know, Diraj, do you want to add anything there? Diraj, I think you're on mute.
Yeah.
Sorry about that. I was on mute. Yeah, so I think, Luke, you covered the bulleted points. I would just like to kind of highlight more on the auto stewardship, what we do at the state level, and also talk about the little bit more kind of how the QEs or the different regional entities are playing a key role here. So because we're getting a multiple kind of a data from the multiple sources, and these data so let me take a step back. Let me start. We are like an MPI of an MPI. So there are multiple MPIs which are connected to another MPI, which is at the state level. So a lot of data auto stewardship is done at the QE level. And then when the data comes to us, we take it and we try to feed it. Our algorithm is like a tune to a kind of avoid any kind of accidental, I will not say everything, but avoid the majority of the accidental data matching and linking issues. The threshold is very high. So if there's a possibility of patient doesn't need to be linked, or there's even 1% of chances of having a risk that doesn't get linked, they will be going to the task level. And that task is what we work on creating we work with another referential matching system where we validate the data. So we take the two patients which are under question, we send that data to the referential matching and ask for like, hey, based on your all data you have about these two patients, can you tell us if they are the same or different, or you don't know? And based on their response, we kind of update SMPI. And we do not have we have restricted the same source duplications. So we do not allow if we find like the patients are duplicates from the same source. So we kind of keep that as a duplicate task and work with our participants to kind of get that stuff resolved or what to do next.
So a question for you, Diraj. Are you finding that the activities that you have to undertake related to person identity is any different for a fire world than it was a pre-fire world?
I mean, these two are two separate, if I look at the fire and any other standard, right? So patient identity matching is always one of the key player in any IHE world. And I think that should be handled separately than the actual clinical data itself. I mean, the matching part is the one, and then identifying and relating the content or the clinical content to the patient is a two different tasks. So how we say it, like when we have the kind of MPI, we get the MPI, we get the patient data, and we manage the MPI completely at the state level. And we try to keep that process completely separate than the actual clinical data matching and everything happening at the QE side, because we do not keep the clinical data with us. So once we receive a request, I just want to go, because we're talking, I'll just go through the process, what we do. So we receive all this data. There are two different methods we get this data from the our participant. One is we receive the batch file like every night, and then other one is like a live feed, which is happening every second from the source. So we use the PICS IHE, add, update, merge all those profiles, and then there will be another set of queries coming to us saying that I need a data for this particular patient, and that's where we go and query our SMPI and figure it out where exactly the patient is located to, and then reach out to them to get the clinical data from them. So they are related, but they are like two completely separate entities, and they need to be handled by two different teams with the coordination.
Thank you. Our next question, I think, is mostly geared towards Patrick. It seems that FAST is totally missing the principles of privacy, collection limitation, data quality, purpose specific, use limitation, openness, individual participation, and accountability. Has privacy by design been considered as a principled design?
Yep, and thank you, Alex. And I've actually been read that question several times in the chat leading up to this, and I'm not sure exactly where it came from, because as far as FAST initiative, everything that is required by HIPAA, by privacy in general, is supported. Anything that would even remotely touch or cause or be a recommendation to any change in those models would need to go through the regulatory process. So, I'm not really sure of the basis for that. What we're trying to facilitate from a FAST perspective is the ability for transactions with the appropriate security, the appropriate privacy, the appropriate consent to run at scale, not to lessen or any way, shape, or form reduce security, privacy, or anything related to that, but to basically enable it across the ecosystem and have it run at scale, so that it's not, it doesn't, the inability for an actor to participate with another actor, as long as they're both following the appropriate protocols, should not be impinged by things that exist as barriers to the ecosystem in general.
Yeah, I think that's a really helpful answer, Patrick. Having been involved in HL7 fire activities and with FAST, as well as some of the role that I play in the National Committee of Vital Health Statistics, there's sort of this missing understanding that it's not about building fire at scale that's all sexy and new. It's about taking the investments we've already done, leveraging the fire standard, and being to build out the ecosystem and the investments we've done from policies and technical and workflow perspectives. And so the cornerstone of HIPAA Omnibus and some of the privacy principles that were mentioned in this question are really already baked into everything we're already doing. So I think it's a pretty important, we're not throwing the baby out with the bathwater, we're just warming up the water. All right, so next question that we have, I think I've already called out some of the links, so I'm going to go ahead to skip to the next one. Let's go to the question for Meditech. How has Meditech been helping clients get compliant to the new Cures Act as it relates to interoperability? Is Meditech performing frequent readiness assessments for the role? Jason?
All right, I'll stop typing my answer and I'll just answer it verbally now.
Okay.
So Meditech, as a company, we created a task force that fully reviewed the rule. The task force was built up from multiple different functional areas of the system: interoperability, chart, physician documentation, all those different areas, to kind of fully review the rule in whole, and then start to apply it and review each of our platforms and determine what changes needed to be made. Then, based on the changes that were needed, we started to break down those through our development processes that we standardly use. What are we going to do for provenance, clinical notes, etc. We are now in the process right now, literally today and every day for the next couple of months, reviewing everything that needs to be done, setting timelines, making sure that we're meeting all of the 6 months, 12 months, 24 months, 36-month timelines that are in place, and then getting that information out to our customers as soon as we can. Some of the things are still in process, so we haven't made announcements on them. But yeah, we're continually assessing everything that needs to be changed for each platform to make sure that we're going to be fully compliant for each of the dates.
Thank you. All right, so there's a follow-up question, Patrick, for you. The question on privacy principles is related to a lack of any mention of privacy in the FAST architecture. There is no patient engagement methods, there's no accounting of disclosures or access log, and there's no mechanism for a patient to request changes. And if there seemed to be no mention that the patient is an active participant, FAST seems to be focused on organizations and government access.
Okay, so there are a lot there. So let me read the question again, Alex.
Which may be challenging because it's not only in the new questions portion, but it's also in the answered portion.
Okay.
I think there's some layering of assumptions here of the work that we're doing. It's kind of how I feel like we have been making sure that the patient at the center of it is part of what's driving all of us, and trying to get the better discrete data flowing and the obligations that entities have in regards to accounting of disclosures, consent management, minimum necessary, appropriate release of information under certain provisions, and the exceptions under the privacy rule or the SAMHSA rules are an inherent component of what we're doing. But Patrick?
Yeah, so I've got the question up here. Thank you. So to kind of break it apart, there's any mention of the privacy in the FAST architecture. So I think we did talk about, the fact that as far as authentication and authorization to data is covered under the security model that we talked about. And so it doesn't mean to describe, or it's recognizing what is in play for privacy as it exists today. There's no patient engagement methods. So FAST in and of itself was born out of a need to facilitate interaction between entities. So for example, payers, providers, those types of actors. The concept of patient engagement as it relates to, I think, if there is, to request changes. For example, if a consumer or patient recognizes that data is incorrect or is disputing data that went from point A to point B. I think that's the nature of the question. So FAST in and of itself is not, doesn't specifically address, the mitigation of a potential data issue. The fact that it would have to go back to the originating source or being handled by the processes outside of the FAST initiative. FAST is concerned with running FHIR transactions at scale, not ensuring or is not concerned with the fact that if data is incorrect or is disputed in system A and is going to system B, the FAST initiative in and of itself doesn't address that specific issue. If the information in System A needs to be corrected, then System A needs to be corrected. Active participant, mentioned that the patient is the active participant. So I think I'm seeing a common theme here. Maybe let me step back just a sec. Is the FAST initiative, again, was meant to mitigate any perceived barriers to running transactions between entities. It did not specifically address consumer-mediated exchange, although in the second batch of the use cases that we created, making sure that consumer-mediated exchange was certainly planned for or accounted for. So all of the solutions have some level, not all of them, because like directory and those, but each of the solutions and most of the solutions in some way, shape, or form attempt to address consumer-mediated exchange. But in and of itself, FAST is concerned with exchange of information at scale across entities, respecting the existing privacy, security, or not privacy and consent models that are in play.
Thank you. We'll see if we get a follow-up from that requester, but I'd like to move on in consideration that we have a few more questions coming in. This one's kind of a broad panelist ask, so let's run the gamut here. Whoever wants to go first, but I think everybody might have an interest in addressing the question about your thoughts on the role of implementation guides versus core FHIR. So I think that the requester is looking for some information from your perch about the criticality of implementation guides and the U.S. core FHIR standard. Any volunteers to go first?
Alex, I can make a brief comment. This is John. So we have a full FHIR implementation guide for electronic case reporting, and one of the ways that we use that is to identify just the specific data that are appropriate to exchange for electronic case reporting on the basis of state laws and HIPAA. So in terms of defining the scope of the data that should be implemented, should be reportable, is one of the uses for the implementation guide.
Okay. Anyone else want to talk about the their view of implementation guides versus the FHIR standard?
So this is Raj, and I think I have a question on that question. Is it the kind of a questioner is trying to understand the implementation guide versus the core resource or the core FHIR calls, or it's like the US core? Because the US core itself has the implementation guide. So, and if it is like an implementation guide, I will say like implementation guide is definitely needed for any project. When you're trying to kind of define the scope, you're trying to build what APIs you're going to expose, what kind of features you will be exposing out to your kind of a community, or anyone on the internet wants to use it. The implementation guide is the kind of a right approach and the perfect way to go for it. And if my understanding is like it's not US core, if it's just only core resources call, I think that should be still kind of it's up to the implementer, because I don't think the FHIR is enforcing any kind of regulation that you cannot go ahead and use the core resources as it is.
Anyone else want to talk about IGs versus the standard? Jason?
Yeah, I mean, I think for the most part, the IGs for Commonwealth specifically, and I guess they're mostly just about those are the use cases we want to try to adopt. Like the IGs are great for that. Like you want to do FHIR scheduling, you want to do US core implementation, you want to do, all the different things out of Da Vinci for payer to payer and payer to provider. Like all those are those different use cases. And as people bring those IGs to the different networks, you can start invoking those use cases quickly because you already have an IG and you just get to point to it. You can say, oh, you want to do CDAX. Okay, here's the IG. Okay, let's go put it in the work. You don't have to build the standards, and that's as I kind of alluded to earlier, for a lot of the trust frameworks and the networks, like that's how we want to operate. We want to say, hey, these members want to do this use case. This use case has an implementation guide. That's great. Our work is, half of our work is done. We have the IG. We can just go implement it now. We don't have to do all the the build up work to say, okay, how do we do this and how do we make it manageable? Like that's where the IG comes in and benefits us a lot.
So I think it's really important to be clear that implementation guides really do give you the rules of the road to accomplish a specific task. And that is a tremendous resource of all those organizations that have been coming together that Patrick showed us on the one side with Argonaut and Codex and Gravity and DaVinci. But Patrick, go ahead.
Yeah, no, I think you actually covered it well, Alex. And just to add a little bit of color commentary, the fact that, as far as, using the base FHIR, right, or US Core or whatever, as long as you understand the basics of FHIR, you can interact and do, patient search, patient match, and that type of thing. The beauty of implementation guides is that in many cases, these use cases orchestrate several of those exchanges together. For example, if you've got something like prior auth or like Jason said, CDEX, and you're using potentially many FHIR resources or a series of interactions, the implementation guide defines all of that. So it's, basically using the building blocks of what we do from a base FHIR perspective and adding the functional use case and completely defining it right on top of it without having to reinvent it for every implementation that you're trying to do.
As one of our attendees just noted, an IG actually provides for uniform and consistent use of the base HL7 FHIR specification. Very well said, Rachel. Thank you. Anybody else on the panel like to weigh in here on this topic? All right, John, we've got a question specifically for you. Is electronic case reporting now app only for COVID reporting, or is it all disease reporting?
Thanks. So this is another testament to the capabilities of FHIR, I think, but the ECR Now FHIR app actually can do either full electronic case reporting, which is now at the level of 89 conditions. But most of the implementations we're doing are strictly for COVID-19 because of the health system and the public health agency's desires to focus their activities. But by using the app, we are actually implementing the technologies that can do the full thing, can address full electronic case reporting, the 89 plus conditions, and making it available. And as soon as COVID is no longer the focus or the most prominent focus, knock on wood, that can just be turned on as a reporting function. It's literally a configuration change.
So, John, building on that discussion of COVID being a catalyst to move us all forward with more effective information exchange and public health reporting, can you talk a little bit about how you see the landscape in public health changing as we move forward in being able to further extend the FHIR standard? Because you did note that this is all still being rolled out, that public health has very much been a 2.x HL7 standard based transaction kind of environment. How do you see COVID's experience and FHIR becoming much more ubiquitous in public health?
I think FHIR will help tremendously over time. And there are some great opportunities for public health agencies to advance their technical implementations now. It is the public health paradox that at the same time that it's the worst of times for doing work, it's the best of times. Public health tends to get funding in big boluses associated with emergency events, and then the attention to public health funding doesn't always continue in a consistent way. So it's really important to take advantage of that now and to try to move the infrastructure forward. And that's part of what we're doing with electronic case reporting. So we're implementing for COVID-19, but the infrastructure supports full electronic case reporting. And we can convert to the public health agencies using FHIR-based solutions readily from what we're implementing. At a more higher level, the public health is about implementing at scale, and it is about implementing in a way that comports with the specifics of state laws that actually drive what is reportable. And working with HL7, we have identified an electronic case report implementation guide for both CDA and fire that specifies that set, that identifies it as the minimum necessary for that purpose, and that allows for the transmission of that from health systems to public health agencies that they don't really well know necessarily, or that they don't know individuals that are fulfilling those roles. So that whole paradigm of networked exchange, whether it be push or pull, is a really important one for public health moving forward. And the concept of the policy framework that we've already achieved also during COVID of the e-health exchange, care equality, and Commonwealth all lined up to support that is really a huge step forward for enabling those technologies as well.
Thank you. All right, we look like we're about coming to the end of the session. Thank you for all of your time and insights in the value of using FHIR and the capabilities that it's going to enable in the marketplace, as well as the implementation challenges that you're all addressing. FHIR is something that is becoming much more part of our landscape in the United States healthcare system. This idea also that John was sort of getting at, which was our ability to use national standards and to be able to record data and then reuse it in various ways to support minimum necessary objectives, is at the heart of all of our ability to roll up our sleeves and get engaged with the standards community, and ensuring that as we move forward with harnessing modern technologies and contemporary integration capabilities, that we're making sure that all of our use cases are met, and implementation guides are the best way to ensure that we can truly become interoperable. So thank you for all attending. We look forward to the next ONC Tech Forum. Have a great day.
Thank you, Alex.
Thanks, guys.
Thanks, everyone. Bye-bye.